Hello and welcome to this KOMO News Town Hall. I'm Steve Solis. As you may know, President Trump recently signed a massive spending bill that has been coined the Big Beautiful Bill. And this bill means trillions of dollars of tax cuts. But we're also learning it could mean big changes to our nation's healthcare system, specifically Medicaid. In this town hall, we're going to dive deep into how projected cuts to our state's Medicaid program could impact Washingtonians. We will share the data and figures that state leaders are working with. We will also hear from Katz, Principal Lecturer Emeritus at the University of Washington's School of Public Health. He has 46 years of experience in health policy, which gives him both invaluable knowledge and perspective. He will help us understand the changes that are coming while helping to separate fact from fiction. But the first thing to note is how Medicaid here in Washington works. In this state, Medicaid is known as Apple Health. According to the Washington State Healthcare Authority, Apple Health provides medical, dental, vision, and behavioral health services to Washingtonians who qualify. The state says more than 1.9 million people across the state were enrolled in Apple Health as of June of 2024. The programs and services provided by Apple Health are both state and federally funded. The Healthcare Authority says federal funds pay about 50% of most traditional Medicaid programs and 90% of Medicaid expansion under the Affordable Care Act. Joining me now is Katz, who is no stranger to public health policy. You've been working around it for quite some time, right, Aaron?
Yeah, I've been working in health policy in the state of Washington since the late 1970s.
Okay.
So yeah, a few years.
And so you've seen quite a bit of change over the years as well.
Yeah, I've seen a lot of change, a lot of ebb and flow, and I think we'll get to talk about some of that ebb and flow, but. Yeah, it's been, healthcare is an important topic for lots of people. And I've been fortunate to be able to observe and be part of some of the changes that has helped them.
Based on what you've seen, and again, we're going to dive a little bit deeper into detail here, but just as an overview, how serious is this move and these changes that we could potentially see?
Oh, I think it's incredibly serious. I mean, this is... Prior to this law being passed by Congress, generally speaking, the federal government lets states within a framework, let states take their own initiative in ways that they felt best, for their populations. This law imposes very large changes nationally, that is everywhere across the country. And that's very, very big.
Okay. We're going to dive into some of those changes right now. Of course, one of the biggest ones that we are seeing is the impact of federal work requirements. And according to Washington's HCA, by December 31st, 2026, states are required to institute work requirements as a new condition of Medicaid eligibility for adults aged 19 to 65 who receive full coverage. So this makes coverage contingent on working, training, or doing community engagement of some sort, 80 hours per month. And this applies for all individuals aged 19 to 65 who do not meet an exemption. How serious is having this requirement in place?
Well, it's very serious for a couple reasons. Let me just back up for a second. It's important to realize that if you look at the whole population of people covered by Medicaid, there's a segment about 30% of those folks who are covered are exempt from work requirements under this law because they are, as you mentioned, they're in training, they're in educational programs, they're primary caregivers, or they have a significant disability. If you look at the other roughly 70%, the vast majority of them, roughly 64% of the 70% work. So the vast majority of people who would be required to work are already working. So the question is, what about these other, say, 7 or 8%? How significant will that requirement be in their lives, number one? And number two, how much is it going to cost to try to make sure that they're working? So I just want to emphasize that the vast majority of people who would be required to work under this law are already working. They're already working.
Okay. The state goes on to, as they post this information for us, Medicaid enrollees work. Most Apple Health clients do work or are the dependents, as you were talking about, of a working adult. The state believes that more than 620,000 adults would be at risk to lose or delay coverage because of administrative red tape, assuming that similar experience from other states. An estimated 187,000 Washington adults will lose Medicaid coverage. Does that sound accurate to you?
Yeah, we have lots of experience in this state, as well as most states, with using administrative barriers, we'll just call them that, administrative rules, to reduce the number of people on Medicaid. Generally speaking, politicians don't like to come right out and say, we're cutting 180,000 people off of Medicaid. We're not doing that. What we do is, and again, many states have done this historically, looking back 40 or 50 years, have instituted, as this law does, a requirement that you come into the office or somehow do it online and re-prove that you're eligible every 6 months. Every time you put up a barrier like that, there are going to be some people who can't get over the barrier, not because they're not eligible, but because they can't get to the office. The communication from the state saying you've got to come in isn't received. Maybe it's a bad address or email address or a physical address. People can't take time off of work. It might take an hour or 2 hours for someone to drive to an office. There are many reasons why people who are otherwise eligible wouldn't be able to meet that requirement every 6 months. And so I think reasonable expectation is a whole bunch of people are going to fall through the cracks, not because they're not eligible, but because they can't meet these new administrative requirements. We've been doing it for a long time. So we know that administrative barriers result in people dropping off Medicaid.
Okay. Now, the state does say that they could apply for a waiver. States may apply for a waiver to delay implementation all the way to December 31st of 2028, but the state has to show that there are some good faith efforts being made. The question I have is who's making that call to say if a state can essentially qualify for a waiver, and then what?
Yeah, it's the Department of Health and Human Services, the federal agency that oversees Medicaid and Medicare, that's run by RFK Jr. Now, they would determine whether a waiver request from a state meets whatever requirements. They're going to have to develop a set of rules that basically say, here's what you have to do in order to get waived from this requirement. But of course, sort of political perspective matters. So the federal administration's sort of perspective on work requirements, for example, would have a significant effect on the willingness of the administration to grant these waivers. And it has worked the opposite direction, by the way, in the past. Particularly Democratic administrations have been very reticent to allow states to institute work requirements in Medicaid. And only a few states have been able to do that, Georgia and Arkansas among them. So the political sort of perspective of the administration, the federal administration, would play a role in how strict they're going to look at waiver requests, for example, from the state of Washington.
Okay. I want to dive a little bit deeper into the red tape, so to speak, because this is also this bill, this new law, increasing the frequency of eligibility redeterminations. Require states to redetermine eligibility for adults enrolled through Medicaid expansion for adults every 6 months. So that begins December 31st, 2026. Will lead to thousands of people losing their coverage.
Right.
80 to 85% of the population automatically renews, but 15% of the population who needs active management will drive significant staffing impacts for HCA, DSHS, and HBE.
Yeah. Yeah. So if you think about this, that so you have a population on Medicaid. You know, it's roughly 2 million people, about 900,000 children, who have all kinds of different life circumstances. You know, working, not, living in a remote area or a rural area. Have stable housing, so they have an address that is good. They have phones that work. All of those things. So the state is going to be required to communicate with them and say, okay, you now have to come in or go online, whatever the process is going to be, in order to prove to us that you're eligible. So a number of things have to happen. One is the information, the contact information has to be accurate and up to date. The communication techniques have to work for the people, for whatever circumstances there are, and so those things have to sort of sync in order for somebody to know in sufficient time that they've got to re-up. And again, it's just expected, because we have so much experience like this, that we're going to miss people. We're just going to miss them. They've moved, or they've changed phone numbers, or whatever the glitch is. And again, we have experience in Georgia and Arkansas that got waivers from the federal government to require people with Medicaid to look for work or be working. They had significant problems just in the communication, just letting people know that they now had to come in and jump through the hoops.
I would imagine too, and I'm speaking from life experience when I talk about this. I don't have any data to back this up, but I grew up in a poor household. I mean, we often had assistance to put food on the table. But I remember we moved a lot as a kid because rent was going up. We were constantly trying to find the cheapest rent we could. So I would imagine when that comes into play for some families who are on Medicaid and who are having to move to make sure that they can keep a roof over their heads, that is potentially a way that people would get lost in the shuffle. Right.
Absolutely. So the residence, where people live, is one variable. The other one is work. So if I have to prove to the state that I am working or looking for work, it means the state has to be able to verify what I say. Okay, so I drive for Uber or Uber Eats, or I deliver pizza for Papa John's or something like that. So the information that has got to be made available to the state to verify that, oh yes, I have met the requirements. I am, quote, working under these Medicare work rules, and so I can get my Medicaid. But gig work is, inherently kind of iffy. It changes. People are working 2 or 3 or 4 jobs. If the requirement is 80 hours a month, what if I'm working 3 different gig jobs that add up to 81 hours? That means the state has to be able to get that information. I'm not a market economist, but I can imagine there's lots of gig work for which the data about individuals doing the gig work isn't all that great, and isn't all that consistent, and maybe isn't connected very formally to state databases. So it's both on as you explained, people move, and lower income people often have to move because the cost of housing is so high, and the work that they're involved in can be quite iffy, temporary. And both of those are going to get in the way of the state having the information to verify that people are eligible.
We also try to get HCA to be a part of our conversation, and as of today, we haven't been able to get our schedules to line up. But I would also imagine that it's not like HCA can add more staff members to keep up with this increased workload. They're probably going to be working harder than they've ever worked before.
Right. Well, I mean, it'll be a budgetary calculation to determine whether they have to add staff and maybe other expenses in order to meet the requirements of the law. Because, of course, if the state is found to be not complying with these new requirements, I don't know what the sanctions are, but given the decisions and behaviors and statements by this federal administration about states not towing the line of the federal government, you could imagine significant financial sanctions if a state is not doing what it needs to do. So this, HCA may well have to increase its staffing. And then the question is, okay, well, where does that money come from? And the state, we know, is in a difficult budgetary period now. And, it's quite possible that it would have to take other actions in order to fund more staff to meet these new work verification requirements.
I want to move to talk about some of the really big impacts, these programs or these services that are received here in Washington State that are Medicaid recipients are able to use. I want to talk about births in Washington State. This, of course, information coming from Washington's HCA. Medicaid paid for 35,400 deliveries in 2024. Essentially, Medicaid paid for 45% of all babies born in Washington from 2018 to 2023. That's quite a bit of Medicaid recipients who potentially could lose out on coverage like this.
Yeah, I mean, the eligibility for pregnant women and postpartum women is a little bit higher. The income eligibility is a little bit higher than for other Medicaid beneficiaries, and that has meant that people who are pregnant and are going to have a child are more likely to be covered by Medicaid now than, say, 25 or 30 years ago. Medicaid has become a very important health insurance program for pregnant people and for newborns and postpartum mothers. Whether that coverage is at jeopardy, I think remains to be seen. About how the federal government over the next few years deals with Medicaid funding, but that's as you say, that's a very big chunk of family life in the state of Washington that Medicaid has a big role in. And as I said before, 900,000 kids are covered by Medicaid.
Right.
It's their, that's their health insurance. And as a result, it's a safety net for the families that they're part of.
I didn't realize this until I started looking into the data, but Washington HCA says that Medicaid is essential to treating opioid use disorder. And the numbers here are pretty interesting, is that Washington Medicaid enrollees, there were 73,000 plus who had an opioid use disorder. And Medicaid is the largest payer for opioid use disorder treatment, and the federal government pays a significant portion of those Medicaid costs. This sounds like it would be a really big one to impact our state.
Yeah, and you could throw in mental health services in that bucket too. You think about lots of people. It's not true of all people, but lots of people who have substance abuse challenges, mental health challenges. Sometimes, as a result, also have challenges getting and keeping a job, right? They tend to be, not often are, have lower incomes, and as a result are eligible for Medicaid, right? So, Medicaid has become a very important financer of treatment for people who are facing those challenges. If the state were unable to meet the needs of those folks for their, opioid treatment or other substance abuse treatment, we'd have a different and a larger problem on our hands, for sure.
Another thing that they post here is that loss of coverage for persons with untreated opioid use disorder will increase uncompensated care costs for hospitals and ERs, jeopardizing the financial livelihood of treatment centers. And we are seeing that treatment centers, as we know, are vital. There are more of them popping up in communities, but if they lose funding, how helpful are they?
Yeah, exactly. And this is generally true of the impact of the changes to Medicaid. If many types of health services have a heavy, they're very involved in Medicaid. Medicaid is a very important source of revenue. So, for example, rural hospitals and clinics and physician offices tend to have a much higher percentage of their client population, their patient population, on Medicaid. So to the extent that Medicaid funding gets tougher to get, dries up, people are dropped off of Medicaid, those providers are going to be under financial stress. And that's true also of providers of opioid treatment, mental health services, again, who tend to serve a higher proportion of their patients, and therefore their revenue is Medicaid. So the fate of Medicaid as a financial source for many health service providers, so goes their fate as well.
All people across the state of Washington will be affected by these Medicaid cuts. People who live in rural areas of our state may be impacted most. KOMO's Chris Daniels recently traveled to Mason County to hear how that community is preparing for these new changes.
They're caring. They care about what they're doing.
Outside the Mason Clinic, Rick Tafoya leans against a building he says has propped him up for decades.
I always had good luck here when I needed their assistance.
Tafoya says he's been watching the news closely, as have hospital leaders.
The challenge and the difficulty of being able to remain open definitely is going to rise quite a bit.
Eric Moll is Mason Health's CEO and says he estimates 5,000 full-time patients will lose Medicaid coverage and reimbursements, but that the bill won't fully kick in for 2 years, likely allowing the small, publicly owned hospital time to plan to avoid closure.
We've been able to do the analysis. We think that we can continue to operate, but there's certain service lines like obstetric care that are most vulnerable because those are disproportionately high Medicaid service lines.
The Washington State Hospital Association argues the change will strain smaller hospitals already with cash flow concerns. The state's Republican Party chair counters the bill will focus service on those most in need.
The problem in Washington State has been we've been extended Apple Health Medicaid to so many people, but the pool of money available has stayed fairly consistent.
Kind of get upset with it a little bit and know that there's not a whole lot I can do but vote and raise opinions.
Tafoya is also of the opinion that he'd like his health care to remain in place.
Like I said, I'm grateful for this place and hope that it'll be available for me for the rest of my life.
Joining me now is Eric Moll, the CEO of Mason Health. Thanks for being with us. We just heard you talk to our Chris Daniels about the impact to Mason Health. What should people really understand here as they still grapple with this information?
Yeah, I think the biggest thing as it relates to healthcare and particular rural is, it's about loss of coverage. And so though simply put, less people in the community will have coverage for basic medical services. And so in a place like Mason County, where Shelton, Washington is, there's about 62,000 residents, and we estimate as much as 5,000 people will lose coverage once this bill goes fully in effect.
One of the things that we have heard over and over since this was signed was that rural healthcare systems will be hit hardest. Does that concern you, knowing just how much people in your community depend on the work that comes out of that building?
Yeah, and it will have a disproportionate impact on rural hospitals and rural healthcare because you have more people in the community that are covered by Medicaid, and so a place like Mason Health, about 25% of our patient population is covered by Medicaid, and in rural markets that could be anywhere from 20 to 40%, and in an urban market, it's going to be closer to 10%.
If somebody doesn't have Medicaid, it sounds like they're still going to be impacted.
Yeah, because what that does is it starts to significantly impact the infrastructure, and so these organizations are going to have to look at service lines and the availability of those service lines. So there may be less physicians that they'll be able to support. There could be whole service lines, when we've seen this over the last few years, just increase of obstetrics, no longer being able to be provided in rural communities. And certainly this will continue to exacerbate that trend.
It'll still be a couple of years until we truly see the impact. Is there anything you can do between now and then to prepare?
Yeah, and actually, I think there's a couple things. One is getting even better at the enrollment process. And that's one thing that hospitals have partnered with the state, and that's a good thing in Washington State, is partnering with the state on enrolling people into Medicaid. And so then many hospitals have their own staff that then work with folks in the state. We have to get even better at that because the work requirements are going to be even more confusing, more complex for folks to be able to fill out that paperwork. The simple things that doesn't sound like that would be a barrier, like the actual enrollment forms. They're pre-populated with information now, and that pre-population just simplifies the process for folks because, again, it's very confusing. So we're going to have to get better at helping folks through that process, and the window to do it is shrunk. So right now you can do enrollment within 90 days post some sort of emergency or acute event. Now it's shrunk down to 30 days to then get that retroactive enrollment. So that's one of the things. It's just getting better at helping our community with that piece. The other piece is just taking this time to shore up our organizations and try to get it as efficient as possible. And that's what most hospitals are doing now, is recognizing, hey, we got a runway. We can't waste this precious time.
As we are still a couple of years out until this really hits, what words do you have to share with your community in terms of providing healthcare in the future as this does take effect?
Well, the words are, we'll still be here. And I think that's the case with almost all rural hospitals. They will still be there for their community, and I'm very confident Mason Health will be here. I think there's a lot of fear that this will eliminate organizations like Mason Health. I think the community is very strong. It's a growing community, and healthcare is still desperately needed, and we will be there for the community.
So we just heard from Mason Health there on how they are expecting this to impact them. What are your thoughts?
Yeah, I think the CEO's response is, is sort of typical what I would expect, which is sort of a mix of warning and hope. Another way to think about the cuts, he mentioned obstetrics. That is what we talked about before, that pregnancies and births tend to be events that Medicaid finances a lot in the state. And to the extent that people who are now covered by Medicaid lose that coverage and yet still have events, whether it's an emergency or having a baby or whatever it is, it means that those costs have to be covered by everybody else. the so-called charity care. There's actually no charity. There's no free care. So care that Mason Health provides that isn't paid for by Medicaid, that used to be paid for by Medicaid, those costs have to be covered by everybody else, everybody who has insurance, everybody on Medicare, everybody who pays, out of their own pocket. So it's a cost shift essentially. And it sounds like the CEO is, sort of working through and trying to reassure his community that they will be able to tighten their belts in order to make sure that the agents, the services don't close. Whether he'll be able to do that, will remain to be seen. We don't know how strong his financial position is today versus, for example, a hospital in central Washington or in eastern Washington. But I'm sure all of the leaders of those healthcare providers are looking at their balance sheets and their bottom lines to figure out how the Medicaid cuts are going to affect them and their ability to continue to provide services.
Staying on the topic of rural health, and this is something that Governor Ferguson spoke about in a statement shortly after Congress passes into law. And he went on to say that in 26 of Washington's 39 counties, more than half the children are covered by Medicaid. In central Washington, 70% of all children are enrolled in Medicaid. Some counties, the number is even greater. For example, approximately 80% of kids in Yakima County and approximately 90% of kids in Adams County are on Medicaid. Moreover, 70% of all births in rural Washington are covered by the program. Medicaid enrollees account for nearly half of all births statewide.
Yeah, the bottom line there is that rural communities rely on Medicaid a lot more than urban communities. And as a result, the providers that provide services to those people are relying on Medicaid a lot more than providers, say, in downtown Seattle. Also significant there, but the numbers that you just spoke, really shows how much of an impact cuts to Medicaid, to eligibility, and whatever happens after that, cuts to payment. It's going to affect rural communities a lot faster than in urban Washington communities.
Okay. We did ask our viewers to send some questions, and we received some of them. So we want to toss them your way. The first one, though, not a question, more of a comment. But I think it's something that we did see, not just hear from somebody who sent it directly to us, but we're also seeing this a lot on social media and in a lot of people who are just talking about this. And they say requiring people to work if they can or volunteer in order to receive medical from Washington is not asking too much.
Yeah, I think a lot of people have a reaction like that. So a couple of thoughts about that. One is what we talked about before, is the vast majority of people who are covered by Medicaid are already working, or they're in one of these groups that would be exempt. They are primary caregivers, they're in training or education programs, or they're disabled. So thinking about this as that's not unreasonable to ask. These people are already working. We sort of in America, we sort of have this assumption about poor people that they're poor because they're lazy, they don't want to work or whatever, which empirically, just by looking at the data, is not true. And it's not true of people on Medicaid. People on Medicaid work, often 2 or 3 jobs, in order to keep their heads above water. My experience in working in this field is that lower income people work a lot harder than the rest of us to stay afloat. And that's borne out by the data around Medicaid. So that's one thing, is that the vast majority of people are already working. They're already working. A second thing is that when you look at if we want people to work, right? We want to help them get into and stay in the workforce. The question is how you do that. So is a requirement for people to work in order to get medical insurance an effective way to do that? And we have a little bit of evidence to suggest that no, it's not. So as I said before, 2 states previous to the Trump administration got waivers from Democratic administrations to institute work requirements in their own Medicaid programs, Georgia and Arkansas. And in both cases, what you find is the states had to spend an amazing amount of money to basically cut people off of Medicaid. So in Arkansas, tens of thousands of people lost their Medicaid coverage as a result of the work requirements, and there was no effect whatsoever on employment, that is, on involvement in the workforce by lower income people in Arkansas. Now you contrast that with a program that happened in Montana. Montana didn't require people to work in order to be on Medicaid, but rather offered a voluntary support system to help people get connected to the workforce. And an evaluation of that program found that someplace between there was an increase of 4 to 6 percentage points in employment in that group, in that lower income group. So the point is that if you want people to work, there are ways to help them, but sort of putting up a barrier in order to get health insurance doesn't seem to be that effective. And let me just tell you a story, a sort of an anecdote that illustrates this. My wife and I, a number of years ago, were driving in, I think it was the panhandle of Idaho. And we were on vacation, and we stopped to stay at this, it was basically a farm, young family, 2 little kids, husband, wife, and they had these tent cabins. So fixed, there was a floor and a bed, and it was a tent, and it was very enjoyable. Saw moose come through, but their life circumstance was very telling to me. The husband had a job during the school year driving a bus for the school district, and he had health insurance as a result. The mother and the kids, their income was quite low, so they were covered by Medicaid, and that allowed them, because there's no way that they could afford health insurance on the income they were getting from these 3 or 4 tent cabins. That allowed them to live a very independent, productive life. They had a huge garden. I think they sold vegetables out of the garden, probably at the farmer's market or something like that. They were living, what looked to me like a very healthy life. Medicaid coverage was key to their being able to do that, to be independent in that sense. I think it's just an example of how, if we turn the paradigm around, rather than you want this thing, this health insurance, you prove that you're working. Rather, we're gonna give you health insurance, Medicaid, to support you in your search for work, maintaining a job, sending your kids to school. It's really in the cliche, it's a hand up rather than what people often think of it as a handout.
Okay, that's something to consider there. And also, I'm very intrigued by that vacation. I'm going to have to check that out. Another question we got here, and this is one we kind of covered, but also not really, because we're talking about a different area here. Will rural communities in eastern Washington see clinic or hospital closures?
It's hard to predict, but we did talk about this a little bit in relationship to Mason Health. Is they're going to be under greater stress because their revenue stream relies more heavily on Medicaid than in Western Washington and in urban Washington. I wouldn't be surprised to see clinics, physician offices, and maybe a few hospitals close as a result. And just to say that, 30 or 40 years ago, we had more hospitals in rural communities than we do today. There have been mergers and already closures, before this. So there's less of a margin for communities to lose their providers. And we know that if a community loses a hospital and a rural community loses a hospital, they often will then also lose their physicians and perhaps if they have a pharmacy, their pharmacy, because they're all of that the financial relationships there are entwined.
Right. Yeah, that's very true. We see that often when we're out in the field covering these types of stories. Another question we got is, will people who gain coverage under Medicaid expansion lose it?
Well, we talked about this before, that the requirements, the work requirements and the administrative barriers that will be put up, or the administrative systems, let's put it that way, that will be put up that will be necessary to verify that somebody is working, and happening every 6 months, likely means that more people will lose coverage. That will include people who gain coverage through the Medicaid expansion under the Affordable Care Act, for sure. It's certainly possible that the state at some point would be in such financial stress that they would sort of rescind their decision to expand Medicaid consistent with the Affordable Care Act. It would be a drastic step in this state. So it's hard to imagine. So hopefully that's not going to come to pass.
Okay. Lastly, will the state have to restrict optional benefits like dental care or substance use treatment?
Yeah, that's a really good question, because again, just like the administrative barriers, Washington State, like many other states over the last 40 years, have used administrative barriers as a way to reduce the Medicaid caseload. As we said before, it's less of a direct attack, essentially, for politicians to do it that way. Another vehicle to control the Medicaid budget, to reduce spending in Medicaid, is to reduce optional services like adult dental care. And that, again, this state has done, as many states have done that a number of times in the past in order to deal with budget stress. So it's quite possible that the state would reduce those optional or cut those optional benefits if the state budget is in substantial stress.
One of the things I really hope people understand here, you can tell me if I'm off base, but we keep talking about Medicaid, but the reality is this is going to impact anybody who receives health care in the United States, correct?
Yeah, absolutely. And not only that, not only everybody who receives health care, but everybody in the United States. Because you look around your own community, wherever you live, and you can, sort of count. You can say, well, 1 in every 5 people I see is covered by Medicaid. 1 in, what was the figure? I mean, almost 1 in every 2 kids I see are covered in Medicaid. If a number of those people lose coverage, what does that mean? We just think, we just went through a pandemic. right? We just had, maybe it seems like a long time ago now, but it's fresh in my mind. Okay, and I remember going into the grocery store, my mask on, most of the people in my town were wearing their masks, but there were a few people who didn't. And one thought came to mind, because I'm a health policy guy, is I wonder if that person has health insurance. Because if you don't have health insurance and you get sick, you're less likely to go seek care. Okay? If you don't seek care and you have an infectious disease, who does that put at risk? Everybody else. And the same is true. We talked before about opioid services and potential loss of those services for some people on Medicaid. Who does? Ask anybody in downtown Seattle or downtown anywhere about the effect of people that are impacted by drug use, who are debilitated by drug use. Who does that affect? Well, it doesn't just affect them. It affects their families and affects the communities that they're living in. So I would argue that the effects of Medicaid cuts that are going to unfold in the next few years are going to affect everybody in our communities.
As people see these headlines and they hear these stories, as this begins to slowly be rolled out, what do you hope that they understand or keep in mind?
Well, I think that. I think that I'd like them to understand that this isn't about somebody that they will never encounter, and it's not about services that they'll never use, and it's not. It's about people in their communities, and it's about services that they do use, or if they're lucky, will be around when they need them, and those services are likely to be at risk. Some of those services are likely to be at risk for them, not just for people on Medicaid, but for them, if the decisions of hospitals and clinics and physician offices is to cut services that are no longer paying enough to warrant that they keep them going. So this is a community-wide. These are going to be community-wide impacts. So that's what I'd like people to understand. This is really not about somebody else.
We'd like to thank Aaron Katz and Eric Moll for sharing their thoughts on this complex issue with us. This will be a topic that will be top of mind for many Washingtonians in the months to come. You can count on KOMO News to continue our coverage as this story develops. Find us on the air and online at KOMOnews.com. From all of us here at KOMO News, thank you for watching. Until next time.